Regression analysis of the vaccine rollout effect on COVID-19 cases.
We decided to do our project from the perspective of a healthcare consulting firm. For a little over the past year, we have seen how daily life has been affected by the COVID-19 pandemic. However, during these past few months, we've seen the distribution of the vaccine across the United States in an effort to combat this virus. As a healthcare firm, we would like to analyze the correlation between vaccine rollouts and COVID cases. This will allow us to determine the course of action we must take in our future business decisions while regarding its public safety and financial consequences. Thus, we are left with the question, should our healthcare facilities respond to vaccine administration programs by reverting resources and funding from quarantine and COVID-intensive products towards traditional healthcare facility needs?
In order to answer this question, we decided to analyze two different models. The first model shows total vaccines per million versus total cases per million. This was done in order to look at how the growth rate of cases is decreasing as more vaccines are being rolled out. The dates range from January 1st, 2021 through April 26, 2021, and we divided the cases by 1 million and the vaccines by 10 million to better visualize the data on the graph.
The second model shows how cases are changing daily as more people are being vaccinated. Due to the empty data cells within the given data set, we were forced to reduce our time frame from March 3rd to April 25th, 2021. We also adjusted our data set according to the 2-week efficacy rate of the COVID-19 vaccine. This allowed us to properly visualize the number of vaccines administered to their corresponding cases, providing an insight into possible herd immunity per 100 people. We used H1N1 as a reference when making our prediction, due to its similarities in transmission and immunity to vaccines. The introduction of the H1N1 vaccine mitigated the spread while improving herd immunity in the United States. With this in mind, we believe the COVID-19 vaccine will exhibit similar effects. For our first model, we regressed the rollout rate over the total population of those infected by COVID. This will be used as an overview to see how vaccine distribution influences the growth of the total population of those infected by COVID within the United States. Our dataset is within the time frame of January 1st to April 26, 2021. The first regression produced a residual standard error of 0.2412 coupled with a high adjusted R-squared value of 0.9966, which implies an accurate representation of their relationship. According to our model, predicted values may deviate from the best fit line by up to 240,000 cases per million, with 99% of the variance in responses being linked to the actual distribution and/or administration of vaccines. The F-statistic and p-value of 5,880 and 2.2 e to the negative 16th respectively support our claims of accuracy. A high F-statistic relative to the size of our dataset implies a strong relationship between the regressor, vaccine rollout per million, and the dependent variable, total cases per million, at a statistically significant level given the p-value being below the threshold of 0.05. There are no signs of heteroscedasticity or distribution problems in the model because of the uniform distribution of the points. We then applied our training data regression over the remaining 20% of our data. The descriptive statistics produced by our second model mirror the results of our first regression. A residual standard error of 0.2583 and an adjusted R-square value of 0.9961 illustrate relative accuracy according to our training data. Again, this model produces slightly lower predicted values compared to their actual values, proven by a small positive residual standard error. However, the relationship between the regressor and dependent variable is still statistically significant, meaning the administration of vaccines actively influences the total number of cases in the United States. One important distinction between the two datasets is the slight discrepancy in residual standard errors. The increase from Model 1 to Model 2 may indicate that the total population infected by COVID is influenced by other explanatory variables. This would explain the increase in the range of how off our predicted values are regarding their true values. Another concerning aspect of our first two models is the relatively low RMSE values of 0.233675 and 0.233125, respectively. Since RMSE is a measure of the standard deviation of the residuals, a low value implies a possible overfit of the model relative to the dataset. For our third set of regressions, we analyzed the rollout rate over new daily confirmed cases. Figure 2a represents the 80% training data that is illustrated through the graph alongside the descriptive statistics. To depict the relationship between the rollout of the vaccines and the new daily confirmed cases of COVID-19, we applied a polyregression per OLS similar to our previous models. A residual standard error of 5.256 shows a relatively small deviation from the line. In the context of Model 2A, predicted values may deviate from the best fit line of up to 5 million newly reported cases. The f-statistics and p-values of 82.53 and 2.2 e to the negative 16th strengthen our claims of accuracy given the considered data set. In this situation, our high f-statistic entails a strong relationship between the regressor, vaccines administered, and the dependent variable, new daily confirmed cases. However, there are signs of distribution issues within the figure, as the alignment of the points is not uniform. We will explore the severity of this potential issue through the validation process used in the previous regressions.
Our fourth regression model with the corresponding descriptive statistics is shown in Figure 2b, depicting the last 20% of the dataset. This is necessary to verify validity considering the aforementioned issue found in Model 2a. Model 2b produced similar descriptive statistics. Note, the residual standard errors from Models 2a and 2b are 5.256 and 5.509 respectively. Although the residual standard errors differ slightly, the dataset is still relevant in observing the correlation between the two variables given the high adjusted R-squared value of 0.8819 in Model 2b. This model shows similarity in the p-value and f-statistic results, further supporting the relationship between the two variables. The slight discrepancy in the new daily confirmed cases could suggest the exclusion of other explanatory variables. When examining the RMSE values of Figure 2a and Figure 2b, the low values of 4.909 and 2.72 respectively suggest an accurate fit in regards to our training model in correlation to its predicted model.
The two sets of regression analyses depict a strong relationship between the reduction in the overall population infected with COVID-19. It also demonstrates a strong correlation between a decreasing infection rate and the actual administration of new vaccines. Although our results had relatively high adjusted R-squared and p-statistic results, we must be aware of the potential problems within our dataset. Our first two regressions presented in 1A and 1B show signs of overfitting, and they do not give a lot of information on how cases are changing daily. So we decided to employ the next set of regression displayed in models 2A and 2B. Despite the limitations in our dataset and small discrepancies in the RMSE measures, we still produce statistically significant results for both sets of regressions according to their p-value and f-statistic measures. The two models show how cases are changing daily compared to total vaccines administered. In order to get a more accurate and clear analysis on our regression models, we would need more data. This is because vaccine rollout is relatively new and a good majority of people are still waiting to be fully vaccinated. Additionally, vaccines take about 2 weeks to take full effect. We would need at least a month to see more noticeable changes in cases and create a more definite regression model. Although our analyses provided significant information that was able to capture the beginning of the COVID-19 vaccine's effectiveness on infection rate. With a limited time frame, we were able to make a decision based on our regression models. This significance in our findings suggests that our company should begin to plan the reallocation of assets from COVID-related treatment for patients such as ICUs, quarantine zones, test kits, etc., to other disciplines within our healthcare facilities. The planning and future execution of this transition should help mitigate losses when the time comes to dispose of our COVID-related materials and employ regular healthcare facility regulations and processes. With this in mind, our healthcare consulting firm will begin the process of instructing facilities to incorporate normal healthcare practices and facilities at the expense of COVID-related equipment and safety measures as the U.S. population continues to be vaccinated.